medical pointer. And I'm going to discuss today membrane-proliferative glomerulonephritis, where I know you heard a lot of basic since yesterday and a lot of pathogenesis. It was excellently provided, and I'm going to provide you with a bit of an update rather than I'm going to talk about basic first and an update. I'll start with this question and I'm going to end with it. And I want an answer at the end of the talk. Is membrane-proliferative glomerulonephritis a disease or a histological definition? So what I'm going to discuss today is, my talk is going to be in 3 parts. I'm going to talk about definition and pathology, about the pathophysiology and classification of membrane-proliferative GN, and then I'm going to cover briefly the HCP-related and cryoglobulinemia. So let's start with the definition and pathology. Typically, as its name, and as we say always in glomerulonephritis, always go back to the name. Membrane-proliferative means that we have membranous affection in the basement membrane, which is thickened, and it means that we have proliferation. Proliferation here, actually it's dual. It's mainly a mesangial proliferation, but can present with endocapillary. This is one of the oldest patterns which have been described in the history of renal medicine. Of course, Richard Wright, which is one of the fathers of glomerulonephritis, and in the classification by Former, but really the first modern and proper description we follow till now is the one which was introduced by René Habib in 1961. Other names which are more or less obsolete we do not use, but just that you know it. Mesangial capillary, a lot of people still use it, and it's been introduced by Shirk in 1970. It used to be called hypocomplementic, very justifiable to be called hypocomplementic. Persistent or chronic glomerulonephritis, it still is, and a lobular glomerulonephritis may be the least one which is used. Clinically, this disease presents actually with all the nephrology textbook. It has a very variable clinical presentation. Patients can come with non-nephrotic proteinuria, with a nephrotic syndrome, with a full-blown nephritic syndrome, with something in between nephrotic and which is nephrotic-nephritic. They can present with hematuria. They usually have decreased complement levels. They can have an increased ASO dip. They can present with an acute renal failure, rapidly progressive presentation, or can present with chronic kidney disease. And at the end, the histology could be a membrane-proliferative glomerulonephritis. Why this variable clinical presentation? Because there is a difference in the pathogenesis of this disorder, and also there is a difference in the timing of the diagnostic biopsy relative to the clinical course. So you can get a variability between what we see in the biopsy and the clinical presentation of the patient. Typical morphology of membrane-proliferative glomerulonephritis. You get mesangial hypercellularity, as you can see here, and as the arrows. That's the problem with the arrows. So you get a mesangial hypercellularity. You can see that the mesangium here is proliferated. This is not a pure mesangial proliferation. All this pink material in the background is also mesangial matrix expansion. Yes, you get capillary wall remodeling, what we know as double contours or duplication of the basement membranes. Can you see the duplication? I don't know if this thing is going to work or not. It's not working. Can you see it? That's better. Here. Yeah, the basement membrane is duplicated, and it's duplicated here as well. And as you heard, and you know that this is not splitting of the basement membrane, this is interposition of the mesangium. As you can see in this nice EM photo, this is the basement membrane, and here is the mesangium interposition between both, which would result in a lobular accentuation of the glomerulus, hence its name, which was lobular glomerulonephritis. And you feel that the glomerulus is more lobulated. Every lobule is separate from the other, as you can see in this silver stain. Again, this is the glomerulus, this is the tubules with the tubular base membrane stained black, and you have the interstitium, which is you have an inflammatory infiltrate. Typically, your H&E, membrane-proliferative glomerulonephritis pattern, you can even see on the H&E that the basement membrane is thickened and duplicated, that you do have 2 basement membranes. Sometimes the proliferation is not that prominent, and you get more the basement membrane thickening. Other times you get more the mesangial proliferation, In other times, you have more mesangial matrix expansion, more endocapillary proliferation versus the mesangial proliferation. You can get the neutrophils there. This is another example of MPGN, and this is a nice silver stain which shows you again the duplication of the basement membrane and actually the deposits which are there. Sometimes patients, yes?
Fibrinoid necrosis here?
No. Why did you say this is fibrinoid necrosis? No, this fibrinoid necrosis is homogeneous. You do not see the nuclei. It's more or less structureless and usually more pink than this. And يبان بفاقع كده. يعني هو it attracts the attention because it's really pink. No, this is an older stage of MPGN. This is where the mesangial sclerosis actually overcomes the proliferation. And this is one of the patterns which has to enter differential diagnosis with nodular sclerosis. Sometimes you don't know whether this is an membranoproliferative or a diabetic glomerulosclerosis or a light chain. So bear in mind that membranoproliferative enters, again, an old membranoproliferative would enter in the differential diagnosis of nodular sclerosis. What do you think of this? A nice membranoproliferative, yes. Duplicated basement membrane, you have actually segmental endocapillary proliferation.
What about it's right, it's visceral proliferation? This, yes.
This one. This is irritation of the epithelial cells. Any disease which, if maybe involves podocytes, you see it more common. But if you have a podocyte involvement, it's quite common to see irritation of the epithelial cells. These are not crescents. And I'm sure you, as you heard today, the crescents has to have macrophages. In them, you need to see inflammatory cells. Sometimes they are extremely difficult. Sometimes the hot chocolate, a total crescentic pattern, which is very difficult to differentiate. We call them pseudo-crescents. But this one is really small. You can see it usually with a lot of podocytopathies. Okay, so we all agree that this is a membrane-proliferative glomerulonephritis. Okay, this is not a membrane-proliferative glomerulonephritis. This is a thrombotic microangiopathy. And this is another important point, especially for pathologists to bear in mind, and for clinicians who can get a report for justifiably diagnosed by a pathologist as a membrane-proliferative GN, and your patient does not fit being a membrane-proliferative glomerulonephritis. The whole mark of thrombotic microangiopathy is the basement membrane duplication and the mesangial expansion. It's not the presence of thrombosis, and it lies within the differential diagnosis, and sometimes it's extremely difficult to know whether this is a TMA or an MPGN. And this is where you really need immuno studies, because in thrombotic microangiopathy, the patient, you have no deposits. And thrombotic microangiopathy, by the way, does not equal hemolytic uremic syndrome and thrombocytopenic purpura. It equals a lot of other diseases. So it is viable to see this pattern within the patients, not in the context of hemolytic uremic syndrome or TTP. Again, this looks like a typical membranoproliferative, but the proliferation is a bit less than this, but you have the double contours, and this is chronic transplant glomerulopathy from a transplant patient. It also can mimic exactly membranoproliferative and can mimic thrombotic microangiopathy, which even makes it more difficult in the setting of transplant. Sometimes it's impossible to differentiate between them on the level of light microscope. On immunofluorescence, a typical MPGN type 1, you would get either IgG and or IgM on the in the basement membrane and in the mesangium, and you get C3 and C1q as well. This is a beautiful C3, it's bursting some green florica, and as you can see the deposits, the subendothelial deposits on the immunofluorescence. It's really an impressive IF. What is also characteristic of a membrane-proliferative glomerulonephritis is that you get a lot of macrophages within the glomerulus, and this is one thing which can help between CMA and MPGN, that you can get proliferation and macrophage stain for CD68, and they're usually present intra-glomerular. So what about, this is the classic pathology of what we call membrane-proliferative glomerulonephritis. What about the classification? The traditional membrane-proliferative glomerulonephritis classification, you classified MPGN into type 1, which is the one has subendothelial deposits, the classic type, what we call mesangial, the alternative, or ACAR mesangial capillary glomerulonephritis. Then we have type 2, which is known as dense deposit disease. And then we have type 3, membrane peripheral glomerulonephritis, which is subepithelial and subendothelial deposits, and we all know this classification. This classification is based on histological light microscopy and electron microscopy subtypes, and it has no consideration for pathogenesis of the diseases. It classifies membrane proliferative this way. Just let me show you the electron microscopy. This is a typical MPGN type 1. Can you see the subendothelial deposits? Again, this is the basement membrane. This is where it's supposed to, the epithelial cells to be, the podocytes. They are effaced. You cannot see any more podocytes. You see the basement membrane, and you can see this subendothelial cells. This is the endothelial cell, and we have the capillary lumen here and the urinary space outside. So you can see the subendothelial more apparent here. Again, the basement membrane. You do not have much of podocyte effacement here. You can still see some podocytes. You see the endothelium. You actually see the second basement membrane. Here it is. Can you see it? This is the complication. There is one basement membrane here, and there is another basement membrane here, and you can see the deposits which irritated the endothelial cell to make a new basement membrane. As for type 3, okay, there is still controversy about this type. It's really debatable. Type 3, when it was first described, they came with 3 types. You know, pathologists love classifications. And they adore classifications. They keep classifying and sub-classifying and so on. So in type 3, we have the Bergholder type, the Anders or Anders and Strive type. This one is the membrane proliferative glomerulonephritis plus with membranous features. This one was considered an intermediate type of dense deposit disease, and this one has glomerular basement membrane lamination. In brief, type 3, which we consider just a subset of MPGN type 1, is the type where you get some membranous features together with the membrane proliferative, and you have subendothelial and subepithelial electron dense deposit, and you can get layering of the lamina densa of the glomerular basement membrane, and you feel that the basement membrane is a bit distorted. It's not a very regular basement membrane. And as you can see here, you have some deposits toward the epithelial side, yes, and some deposits migrating towards the subendothelial side, and this is what we call MPGN, or what was called MPGN type 3. Now let me come to type 2, which is dense deposit disease. Dense deposit disease, which was considered or is considered MPGN type 2, whatever way you want to look at it. This is in basement membrane. You have dense deposit in the basement membrane, whether diffuse or segmental. And these deposits are also found in the bonus capsule and tubular basement membrane. Can you see the deposits? They're clear. Even in this, I intended to put a small photo to see how clear the deposits are.
انا سايبه امبارح عشان تشتغلوا بيه. طب الاول عيدي من الاول.
لا يعني احنا كنا محتاجين deposits البوينتر من بدري. So can you see the deposits? And it is known as ribbon-like deposits, and you can see it along the basement membrane. Can you see here? Again, this is the urinary space. You have here the epithelial cells. Here is the mesangium, and you have, this is all this ribbon endothelial cells, and you have all of these widespread dense deposits. These are low power electron microscopy, so you would imagine more. Again, you have here all through really light ribbon, all through the basement membrane, and you have the podocytes, whereas they are slightly effaced, as would be expected. You can get also some.
ثواني يا دكتورة، حضرتك يا دكتورة وسام دلوقتي لو انا هقول ان دي اللامنة ترميزي اصلا افرقها ازاي؟
لا، I need a higher power. I need a higher power than this. And then you can see.
How can I evaluate ان هي thick او لا؟
It is thick. You have all of this, all of these deposits. But this is a low power. This is a very low power. علشان you can see even two.
watches اكتر يعني مش قادرين نشوفها هنا يعني مثلا.
You have two capillary loops اهو. حتة واحدة هنا والثانية. This is the urinary space and the podocyte.
لا يعني انا اقصد معلش سوري فور ذا انتربشن، يعني مثلا هل الحته دي اقدر اقول ادي ديبوزيت هنا اهو تخدم اكتر من الحته دي؟
على فكرة احنا ما يعني we measure at the deposits. But you know if you have deposits it will get thick. Yeah, so deposits per se makes you look thick, makes it look thick. But to know whether the basement membrane is of normal thickness, thicker than usual or thinner than usual, this needs measurement. You cannot just estimate by your eyes, we usually measure it. Look at a higher power, then it's easier to see that this is really a thick basement membrane. On a low power, it's difficult, and you can see the clumps of what is called as dense deposit disease. Again, dense deposit disease. But look here, this is a very nice, podocytes. So within this traditional classification, we have to do immunofluorescence for our patients. So over the next 2 decades, the deposit detected by immunofluorescence started to get more into attention. Yes, the classification is based on the EM findings, but we have immunofluorescence deposits. What we used to be the type 1 would have IgG / and or IgM and complement factors, mainly C3. Type 2, which dense deposit, was distinguished by the fact that you have C3 deposits only, no other immune complexes. Then type 3, the Wertholder variant, typically had deposits also of immune complexes and complement factors, while the other type of type 3, which is Streifenberg's variant, could manifest either the C3 alone or in combination with immunoglobulins. In brief, this has even made it more complicated and perplexing on both sides, pathologists and clinicians. And it's usually at this stage that you need to restart looking at the whole thing with different eyes. The first breakthrough came with this study, not this study. Let me see, regarding the dense deposit disease. What do we know about dense deposit disease? We know that this is a rare disease. It occurs in less than 20% of the population. It is mainly in children and young adults, 5 to 15 years. Both genders are affected equally. Patients can present with nephrotic syndrome and renal insufficiency. It's had a bad prognosis. 50% proceed to end-stage renal disease within 10 years. What about its pathogenesis? We know that these are not deposits, by the way, because these are not immune complex deposits. This is actually these patients have loss of complement regulation, and I'm going to come to this in a minute. They have C3 nephrotic factor, which is an IgG antibody, and they have mutations of factor H gene, and this is their problem. And we know that these deposits are not of immune complex origin, and they are actually alterations in the basement membrane material rather than deposits coming from the circulation. And the evidence is that these patients also get the same thing in the retinal capillaries as in the renal capillaries. This is dense deposit. It can present with a membranoproliferative pattern. Can you see what we call the deposits? I think it's very clear. You can see this is the BST, the basement membrane, and all of this is actually the deposits. On a higher power and on a silver stain, and you can appreciate even more the deposits along the basement membrane here. All of these dense deposits, it raises suspicion even just on the light microscopy level.
النيوكلياي هنا do you have any comment عليه؟
They are a bit irritated طبعا. You have هنا inferior
السايز بتاعه مش كبير.
But this is a very high power. On high power, everything looks big. Actually, on high power, everything looks malignant. The oil emerging. Yes. So, that's how I have.
بس هل بيبقى حجمهم كده؟
Yes. This is what they usually look big and they look strange and look bizarre. This is what happens with high powers in the microscope. And as I said, you can also find them in the tubular basement membrane. Can you see here? This is the black staining, the silver staining of the tubular basement membrane, and it's actually interrupted by the deposits. So you get here the rest of the basement membrane is pink because it is interrupted within the deposits. And by immuno, you get widespread deposition of C3. And even on immunofluorescence, you can appreciate what I was just calling, which is a ribbon-like pattern with these deposits. This is a C3C and IgG negative. This is a negative immune. So is dense deposit disease in membranoproliferative glomerulonephritis? In this international study, which was led by the Renal Pathology Society in 2007, they collected 69 patients with dense deposit disease from all over the world. And they attributed only 25% of them which presented with membranoproliferative glomerulonephritis pattern. Actually, the majority was up to 45% had mesangial proliferation, and these presented with dense deposit 3. The third pattern they recognized is a crescentic pattern, crescentic dense deposit disease, which, and as we mentioned yesterday, in order to say crescentic, you need at least more than 50% of the glomeruli to be affected. And this entity is different from the rest of the entities. This entity is called juvenile acute non-proliferative glomerulonephritis, which is pattern 3. This is a special group of patients which was first diagnosed in Cincinnati Children's Hospital, and they presented with gross hematuria, renal failure, and slightly decreased T3. Their histology had a crescentic glomerulonephritis, and when they looked at their electron microscopy, they found that it was a dense deposit disease, and one patient had actually, I don't remember what.
سوري فور الانتربشن تاني. ازاي يبقى في عندي كريسنت واقول ده نون بروليفريشن؟ هو عنوان البروليفريشن الماكسيمم اوف البروليفريشن از كريسنت فورميشن.
No. Crescent proliferation is a crescent or extra capillary proliferation.
أنا موافق.
Yes, but what we mentioned by proliferative is what
mesangial اساسا.
What mesangial or endocapillary, which is the endothelium and the mesangial.
انا فاهم انما ده من اخر مرحله منه كريسنت فورميشن.
لا مش شرط. No, in vasculitis you get no proliferation. You get just a crescent. You do not get proliferation within the tuft. You are not.
يعني كريسنت الون لوحده هنسميه نون بروليفريشن.
No.
وهتكتبي كده اهو.
أنا بقول إن
لو عندي كريسنت الون without mesangial proliferation أو endocapillary proliferation هقول عليه non proliferant.
هقول عليه non proliferant. That's a non proliferant glomerulonephritis.
which يعني مش قادر استوعبها.
ليه تقول ده؟
لأن في عندي proliferation هي glomerulus parietal epithelium is one of the units.
Yes, احنا بنتكلم على terminology. So let's agree on the terminology. When I talk about proliferative glomerulonephritis, then I mean إن أنا عندي proliferation within the tuft. I consider the crescents extracapillary proliferation. Why? Why is this important? Because this reflects the deposits, the immune complex deposits. And when I have no immune complex deposits in the glomeruli, I do not get a proliferation in the glomeruli. I get an extra capillary proliferation, which is the crescents, which is the case with ANCA-vasculitis and with a disorder like this one. Because we've just been saying that dense deposit disease is not an immune complex mediated disease. So this is the importance. This is why do not look at crescentic as a glomerulonephritis. The crescents are just an expression of the aggressiveness of the diseases. So no, it is very important to know that when we call proliferative or any proliferation of the glomerulonephritis, we are discussing irritation of the glomerulus in response to some deposits somewhere, which is not the case in other diseases. So the important point, I just put this slide not to elaborate on it and not to get out of subject, but to know that this disease is treatable. This pattern.
How did they treat these young children?
I don't remember it, but you have the reference if you want to look. I really don't remember, but there is more than one report on juvenile acute non-proliferative glomerulonephritis, and they did include it within the study they did for the dense deposit because of their EM findings. But it still remains that this pattern specifically was a treatable disease other than the rest of the patterns. Pattern number 4 actually presented as a post-infectious glomerulonephritis. And this is also a disease in children, and this is an acute proliferative and exudative, and this is the one Dr. Hussein commented on, and I'm going to say later on, this is the case Dr. Hussein just showed and said that these patients, when they did not respond, they diagnosed them as C3 glomerulopathy. And pattern 5, which was unclassified. So this deposit disease should not be considered proliferative glomerulonephritis. These have different clinical symptoms, a totally different pathogenesis, a totally different prognosis, and has a very high incidence of recurrence post-transplant, up to more than 90%, while regular and proliferative ranges have 30 to 40%. So we do not like to call dense deposit disease proliferative type 2 anymore. The second breakthrough came when we realized that we have something called complement-associated diseases. The more the reports have been coming that we don't see in patients with membranoproliferative glomerulonephritis pattern, just isolated C3 staining, and these are not the ones with dense deposit disease. This breakthrough came due to the work actually of Terry Cockham. They discovered in England, this group, they discovered a special population with what they call C3 glomerulonephritis, and these patients had, I'm going to show you later, had a genetic defect in factor H, with the group of Mayo Clinic, Rochester 1, where they also did a lot of work on this entity, and this French group. This breakthrough said that we have genetic mutations or deficiency in complement regulated proteins in patients which present with isolated C3 deposits. What is complement regulated proteins? I'm not going to go over the complement system, but we know that we have the classic pathway, the lectin pathway, and the alternative pathway, and we know that the alternative pathway is actually always switched on. But these pathways and the inhibition is regulated by a variety of genes. Most important of them is the factor H family, and they are known as regulators of complement activation gene cluster, or RCA. This is the factor H family, and out of this family, we discovered that some patients have mutations within this group and other patients present. The mutations can either lead to deficiency or an abnormality in the balance between the C3 activation and inhibition. And because of this discovery, we came up with the term C3 glomerulopathy. This is glomerular pathology associated with the position of complement C3 in the absence of immunoglobulins. Part of this glomerular pathology can present in a membranoproliferative glomerulonephritis, and part of it is the dense deposit disease. The other spectrum of the C3 glomerulopathies is the case which Dr. Hussein just showed us, which presented in an acute post-infectious glomerulonephritis, and when it persisted, they found that the C3 stayed persistent, and this is why it was termed C3 glomerulopathy. So you see, this is C3 glomerulopathy in new classification. This is the group of patients I was talking about, the Terry group discovered. They found them in an island, and these patients have a deficiency of the complement factor H-related number 5 protein. So where are we now?
That's why it became easier to understand for us clinicians when they did a classification, complement-mediated versus immunoglobulin mediated. We could understand that now.
Exactly.
This used to be very confusing until the Mayo Group published the
complement-mediated, and this is the way we regard membranoproliferative glomerulonephritis now. The way we classify membranoproliferative glomerulonephritis, that it's either immune complex-mediated glomerulonephritis or complement-mediated glomerulonephritis. So how did we progress to this? You have the historical classification, which is type 1, type 2 / dense deposit disease, and MPGN type 3. Based again on light microscopy and electron microscopy. In type 1, you have the mesangial proliferation, the GB amplification, and the mesangial and subendothelial deposits. In type 2, you have the diverse histology I just showed you, and you have mesangial and intramembranous deposits. And in type 3, you have the MPGN with the membranous features, and you have all forms of deposits. They can be mesangial, subendothelial, subepithelial, plus or minus intramembranous.
The nature of the deposits are close.
Where?
The dense deposit.
They are filtration, they are C3 named.
And the complement واحد ولا scratching immunoglobulins?
I'm just going to answer this question right now. So we add the IF to it, and we come up with the modern categories we have now, which are MPGN type 1 and 3. They're still valid so far. And we have this new group which is called C3 glomerulopathy. How do we progress from here to there? By immunofluorescence. If we have on histology and on electron microscopy these patterns, then the immunofluorescence showed that we have immune complexes, meaning we have IgG and or IgM, we have C3 and we have C1, then this is our typical classic MPGN type 1. If the immuno showed C3 only, then this is what we call C3 glomerulonephritis, and it goes under the umbrella of C3 glomerulopathy. Then we come to type 2, which is the dense deposits, and this have been early on, since the first day it was described, C3 only, and this is why now we also include it under the umbrella of C3 glomerulopathy. Then comes type 3, and this follows the same system as type 1. You get the immune complexes, the C3 and the C1, you know that you are in an MPGN type 3, which is just simply a subtype of type 1, just a histological subtype. So you get the C3 only, you are again in C3 glomerulonephritis under the umbrella of C3 glomerulopathy.
You have the same immune complex in MPGN, the 1 and the 3.
Yes, they are the same disease. They are the same disease. Actually, this is, I mean, you can easily drop it.
That is my question. If they did these two categories, we could go with the, like the complement mediated, where you have this group, the C3 glomerulopathy, and the immune globulins that have this type 3 and type 1 together.
Yes. This is, I'm just, I showed this just to show you that development, how it has been developed, how we are actually, but actually, and that's a much simpler way of looking at membranoproliferative. Not only simpler, it makes more sense, it explains the pathogenesis, and it directs the treatment. So what do you do for a patient with membranoproliferative glomerulonephritis? If the patient has immune complexes and a complement, you start investigating for all types of secondary causes for infections and so on.
هو احنا اوريدي الروتين بتاعنا مش بنشتغل الام والاي اف. So you are mostly on the M. So I'm ending up my from two categories, only the M.
This category is not really existing.
Yeah, that's what I mean.
That's what I'm saying. This is what I'm saying. And we are only, yes, and now the classification is actually based on the immuno, not on the EM. So we have either immune-mediated MPGN or complement-mediated. If it turned to be immune-mediated, you need to go and investigate all the causes of secondary of MPGN, infections, malignancies, light chain disease, and so on. If it turned to be complement-mediated, then you need to start investigating the patient for the complement deficiencies, yes, and genetic profile.
انت كده جاوبتي؟
أنا إيه؟
The nature of the deposit.
What I know that they are C3.
انت كده جاوبتي ان the nature of the deposit is C3.
Yeah.
لا انا معترض تماما. لان لا يمكن ديبوزيت قد كده اهو كالكوعه يبقى سي 3 لان السي 3 ده ديجنريتيف بارتكلز وحجمها صغير جدا. يعني انا ممكن اقبلها كومبلمنتري بارت اوف ذا ديبوزيتس اللي فيها اي جي او اي جي ام واي جي او وات ايفر.
So why do you accept it in post-infectious glomerulonephritis?
ما accept برضه بس مش الو.
But no. In actually, in reality, post-infectious glomerulonephritis is C3 positive.
Yes.
You rarely
بس
get.
مش الو.
No. You rarely get the IgG. You rarely get the IgG.
طيب انا عايز اقول.
يعني in everyday work actually, forget the textbooks. It is actually C3 positive.
انا عايز اللي عايز اقوله لك ايه ان السي 3 از سمول مولكيول خصوصا الاكتيفيتد فورم بتاعتها.
So like to remain, what I learned is that small and big is a totally relative thing. يعني I'll give you a very good example. احنا الانتيتي بتاعت chronic lymphatic leukemia, small cell lymphoma, this is a pathological classification. احنا we see it as small cells. But clinical pathology they see it as huge cells. So معترضين تماما على الاعتراض ده. So what is small and large is totally relative.
اللي عايز اقوله ان there might be another pathology ongoing واحنا مش شايفينها اللي هي ايه ان التي immunoglobulins وcovered by complement فانا لما باجي اعمل ستينج I can't detect الا سي 3.
No, I totally disagree. Because if there are immunoglobulins, they are going to be there. I'm going to detect them.
They are there بس blocked مش
No, so why aren't they blocked here?
علشان equilibrium between the IgG and C3. هنا
what I can accept that they look so large and very dense, and sometimes they look thin because they are actually not deposits. They are just alteration in the basement membrane material, which could be an accepted theory. But the fact that they cover up the immune complex, then we are going to have this problem in all our glomerulonephritis. And then in some glomerulonephritis, we are only going to see the C3. However, following up on your بتقوله, bear in mind that this entity is still a very diverse entity. These are different patients, different pathogenesis, different genetic defects. And this is, in my opinion, is a new wastebasket until we see what are we going to do about this patient and come up with new. But the good part of it is that we did good regarding membranoproliferative glomerulonephritis. in the form of investigating the patient, in treating the patient, and in knowing which way we are going in the prognosis. And now we have in medicine a whole new entity called complement-associated diseases, which include a lot of things like paroxysmal nocturnal hemoglobinuria, like of course you know atypical hemolytic uremic syndrome, like age-related macular degeneration, and so on.
And I have to say to the residents of this classification made a huge difference in our investigation.
في حاجه في الميكانيزم بتاعه هو النص ديسبلاي.
Okay,
no, this classification made a huge difference in how we investigate the secondary causes of those all immune, especially the immunoglobulins or the immune complex mediated proliferative. So we don't miss, we don't miss all the causes, but the ones that are complement only. Like this, so we start investigating
the complement, yes.
The different complement deficiency and sending them to centers where they do the H.
Exactly, and this is what we're saying. And yes, as we're saying, the main clinic group, their classification really is
send out slides to this group because we don't have
to Sanjiva, yeah.
To Sanjiva, so he can help us investigate when we end up with a complement. And also, we can detect when there is a paraproteinemia. This is referred to whenever there is an idiopathic picture like this.
So, yeah, so that's, yes.
The previous slide, we have ended up having this complement-free glomerulopathy. Alright?
Yes.
So if I'm going to do the genetic profile and having this deficiency, so I'm going to go and try to remember which is dense deposit.
No. You have dense deposit disease and you have C3 glomerulonephritis. You have two diseases within this entity. Two diseases. Yes, all of these are genetic deficiencies. Complement deficiency, complement problems. Regulation. And they have actually different regulatory genes which are deficient. So you have two entities within this for now. C3 glomerulonephritis and then deposit disease. Okay, I'm going to move to the last part of my talk, which is we know that we regard the immune complex mediated membranoproliferative glomerulonephritis. Now we are out of the C3 glomerulonephritis as idiopathic and secondary, and recently people have been having a lot of queries about the presence of something known called as idiopathic MPGN. Now this entity is really questionable and questionable by a lot of experts, so really investigate your patients well, do your best to see what is behind the patient, because this entity could disappear and do not just decide that this patient is idiopathic. Secondary membranoproliferative glomerulonephritis could come with a long list of diseases, and what I think we care about and what is important for us here is hepatitis C and cryoglobulinemia. So we know that we are the highest country in the world with the highest prevalence of hepatitis C virus infection. We almost have sort of an endemic/epidemic numbers. Hepatitis C can present with cryoglobulinemia glomerulonephritis, with a membranoproliferative glomerulonephritis, with immunoductoid glomerulonephritis, with membranous, which we do see a lot here in Egypt, and with fibrillary glomerulonephritis and some reports of an IgA glomerulonephritis. And I'm going to focus basically on the first two types as honoring the title of my talk. So what are the cryoglobulinemia? What do we consider cryoglobulinemia? Cryoglobulinemia is an in vitro phenomenon. It's the presence of circulating immunoglobulins that undergo reversible participation at less than 37 degrees and redissolve upon warming. These are autoantibodies that bind to the Fc portion of IgG, as I'm going to explain now, and they are formed of IgM most frequently. It is easier to detect the rheumatoid factor actually than the cryoglobulins. What is the classification of cryoglobulinemia? We have three types of cryoglobulins. We have type 1, which is formed of a single monoclonal cryoglobulin. This is the one we see in hematopoietic malignancies like Waldenström macroglobulinemia and so on. And then we have type 2, which is also a monoclonal antibody, but usually it is an IgM directed against a polyclonal IgG. I'm going to explain what is this point right now, which results in what we call a mixed essential cryoglobulinemia, and this is the one which is related to hepatitis C. Then we have type 3, which is polyclonal antibodies, again IgM, directed against polyclonal IgGs, and we see this in connective tissue diseases, in liver diseases, and also in hepatitis C. So the difference between this type and this type is in the IgM immunoglobulin. This one is monoclonal and this one is polyclonal. So what's the incidence of cryoglobulinemia in hepatitis C virus? And you can see this is the result. They are old papers, but they are still very valid, and you can see that up to 100% of patients diagnosed with mixed essential, or what we used to call essential mixed cryoglobulinemia, turn to be HCV positive, and vice versa, up to 60% of hepatitis C patients are cryoglobulin positive, or they have cryoglobulins. So what are these cryoglobulins? What these cryoprecipitates in patients with hepatitis C is composed of. We have a unique antibody. This is a unique antibody, which we normally don't have. It is present as a part of the cryoprecipitate. What is this antibody? This antibody is called an IgM kappa rheumatoid factor. That's its name. And this is why we consider it monoclonal, because you know any antibody should have the kappa and lambda. But this one has only the kappa factor, so this is a monoclonal IgM antibody. And this is a unique antibody which we see in hepatitis C. What this antibody is targeting, it's actually targeting the immunoglobulin gene. It targets the IgG, not any IgG. Which IgG? The IgG, which is attacking the surface E2 protein on the hepatitis C virus particle. So if we take it the other way around, we have hepatitis C. The virus particle has the surface E2 protein on its surface. This is attacked by polyclonal IgG antibodies, and this generates this unique antibody which is going to attack it, and this is what forms the cryoprecipitate, or what we call cryoglobulins. So the cryoprecipitate is an IgM kappa in hepatitis C, is an IgM kappa antibody, is a polyclonal IgG, is hepatitis C virus RNA as part of the immune complex which has been attacked. So why is the pathogenesis? How do we end by injuring the kidney? This is the hepatitis C virus, this is the surface E2 protein. Of course, this virus, or this receptor is hepatotropic, but I also hope you know that this one is highly lymphotropic as well, especially to B lymphocytes. And because of this capacity, you get into what we call clonal B lymphocytic proliferation as a result of the infection of the B lymphocytes with the HCV infection. This clonal proliferation at certain stage switches to monoclonal proliferation, and these patients have B-cell malignancies up to 6%. And B-cell malignancies means that these patients can have lymphomas and can have myelomas as well. But before this stage, within this clonal proliferation, these B-cells start producing the IgM kappa rheumatoid factor. So this is where it comes from these cells. And together, you get the type 2 mixed cryoglobulinemia. Is this what injures the kidney? Is it the deposition of the HCV RNA? No, actually in up to 20% of cases, you cannot detect the hepatitis C virus RNA within the tissue. We think that this is the one which injures actually the kidney. This is the one which is nephrotoxic. This antibody has a small complementary region, and this is the nephrotoxic part. This region is called WA. This is after the first initials of the first patient, they got discovered in it, and this is the actually nephrotoxic part of this antibody. So at the end of the day, you get a restricted monoclonal production of a certain IgM class, which is IgM kappa, and together you get all of this cryoprecipitate, and this is how you end up with having membranoperitoneal glomerulonephritis in hepatitis C. What is the hypothetical progression of these cryoglobulins? We think that the chronic viral infection first leads to polyclonal B-cell activation. And this polyclonal B-cell activation actually gives you in the beginning a type 3 cryoglobulinemia, which makes sense. You generate polyclonal IgM antibodies against the polyclonal IgG antibodies. But then by time, this is a time-dependent process, you get switched, and we all know this, that by time in any proliferation, you are under the risk of having a monoclonal switch at any stage, and you get monoclonal B cell activation, you get type 2 cryoglobulinemia, and this is where you start to have renal affection, and which is nephrotoxic. This is cryoglobulinemia or cryoglobulinemic membranoproliferative glomerulonephritis. See all of these pink deposits within this thrombi, this nice pink thrombi within the capillary lumina, and these are the cryoglobulins, and you can see them here with the trichrome. They also stain white, red, or pink. This is a classic variant, and only when you're lucky you get them this way. And again, you have here the membranoproliferative glomerulonephritis, very nice cryoglobulin deposited in the center of the MPGN. Back to our discussion of differential diagnosis. Could this be a thrombotic microangiopathy? Yes, of course it can be. Of course it can be. Even thrombi sometimes cannot differentiate between both, but you count that you get more arterial lesions. Classically, cryoglobulins present with electron microscopy as organized deposits by EM, and it is said or has been said this is how you diagnose cryoglobulins. What are the typical morphological features of cryoglobulinemia? Cryoglobulinemia by light microscopy will give you a membranoproliferative glomerulonephritis. You have many monocytes with protein droplets in them. You get these hyalines or protein thrombi. They are not fibrin like in TNA, and you can get vasculitis. You can get inflammation in the blood vessels. By immunofluorescence, the protein thrombi will be positive for either IgM or IgG, but more commonly IgM, as this is actually the pertinent autoantibody. And you get predominance of kappa over lambda, which is again expected as we just explained in the pathogenesis. In the electron microscopy, you get organized deposits. This is what you get in the books, but this is not what you get in everyday work. This is not what we see in cryoglobulinemia. Cryoglobulins, or cryoglobulinemia, go through stages as any other disease in the kidney. You have early glomerular changes and you have late glomerular changes. In the early glomerular changes, you get the diffuse glomerular hypercellularity, you get the typical membranoproliferative glomerulonephritis pattern, and you get a lot of macrophages within your glomerulus. You can get the protein thrombi, as you can see here, this is a very nice trichrome, and you have these thrombi, and you can see them, even they are present and apparent upon the PAS stain. I think you've seen enough PAS now, you should recognize the stains on your own. And in the IF, you get the IgM more than the IgG, the classic pattern, and you can see the organized deposits within the electron microscopy. But you get your patients at that stage, not a must. Usually you get your patient after you have been through several phases and episodes of cryoglobulinemia. Remember, this is a form of vasculitis. It can cause vasculitis to an episodic disease. So these are the late glomerular changes. By time, you start to get glomerular basement membrane remodeling, which is duplication/duplication. You start to get more mesangial proliferation and more mesangial sclerosis. If you have seen this, would you have diagnosed it as cryoglobulinic MPGN? Actually, it is. This is what happens by time, and you get mesangial matrix increase, and expected evolution of the disease in response to the deposit. And in electron microscopy, you get dissolution of these deposits, so you do not see the organized deposits anymore. So, and in vascular changes can occur up to 30%, and you can have all the vascular changes you want. You can get a proliferative endovasculitis. This is what we call a proliferative endovasculitis. This is a section of a medium-sized artery. This is all endothelial cells and inflammatory cells. Endothelial cells proliferated together with the lymphocyte. All of these black dots that you see, and this is the typical onion skin appearance we have seen yesterday on a trichrome stain. You can see the entima, and again here, these small pink things are the cryos themselves, which can be deposited in the vessels as well as in the glomerulum. So the diagnosis, the term or the sentence which used to say that the diagnosis of cryoglobulinemia and should only be made when organized deposits are present, this is not always, it's not applicable and it's not true. You do diagnose cryoglobulins on the level of light microscopy and IF alone if you have enough suspicion. And the clinical information, and this is the pathologist, that no cryoglobulins found is no argument against the diagnosis of cryoglobulinemia, because for many hospitals the technique is actually too complicated. And not only in our country, this is a worldwide problem. This is everywhere. So do not count on the fact, neither clinician or pathologist, that you could not detect the cryoglobulins. That doesn't mean that your patient doesn't have cryoglobulins, and cryo is a serious disease. So I'm going to end, as I said, with the first slide. What do you think is membrane peripheral glomerulonephritis a disease or a histological definition? It's just a histological definition, and what makes it a disease is this combination of pathology and clinical. Thank you very much.
انضم الاسم للتربيه المادس الدوله الباثولوجي.
Do we have any questions?
قرأت الكلينيكال كلومينسز اوف ديزيز جبت اي صور من الكلينيكال كلومينسز اوف ديزيز؟
لا، هو كان المفروض في مانجمنت الاثنين have family circumstances يعتذر عن المحاضرة. We have 15 minutes general discussion if you want discussion management clinical or any.
هل في حاجة في الجنرال اكزامينيشن تعمل لي كلوم يكون دنس اوف ديزيز؟
لايف ديستورشن
لايف ديستورشن ده باين ازاي؟
يبقى وشه داخل فوق
يعني